Are we rolling? Well, welcome everybody to the Implementation Science webinar series. And this is, as a reminder, it's where we all get together, faculty, students, staff, administrators from the School of Medicine and also the College of Global Public Health, once-a-month seminar, webinar series to discuss implementation science and to invite top people from the field to come in and guide us through some implementation science hurdles, challenges, successes, and work that they're doing. So we're very delighted today to welcome Dr. Saria Hassan, who's from Yale School of Public Health and the Yale School of Medicine. She's currently the Deputy Director of the NIMHD-funded Yale-Transdisciplinary Collaborative Center for Health Disparities, focused on precision medicine, seeking to reduce the burden of non-communicable diseases among Caribbean descent populations. As lead of the implementation core, Dr. Hassan has led the design and implementation of a multi-site diabetes prevention intervention, which she'll discuss during this seminar. So please welcome Dr. Hassan. Thank you very much for joining us. We're really happy that you're here.
So thank you again for the opportunity to talk today. It was great to come down to NYU, and thanks to Rod again for the invitation. So, as thanks for the introduction. So I'm actually originally from the Sudan. I moved to the U.S. now many years ago for my undergraduate studies and made the good or bad decision to go to medicine. And then it was a long road since then. But I'm actually trained in internal medicine and pediatrics. Did many years in community health. And that's actually what drives a lot of my health disparities research questions, is my many years in community health in many different areas. I've always had an interest in global health and find that through community health and working with federally qualified health center, you do a lot of global health right here at home. And so it's also a great way to kind of bridge what we do here in the mainland U.S. to what we do globally. This morning I gave a talk around my work in Tanzania, which was really kind of my foray into implementation of science, integrating HIV care into a methadone clinic. And so when returning back to Yale, I found an opportunity with Marcella Smith, who's the PI on the key program, to do more implementation science, and primarily around So what I hope to talk to you today about is around my primary project in the implementation core. I'll give you a little bit of background on the epidemiologic transition in the Caribbean, and then give you kind of an intro to lifestyle intervention with metformin escalation, which is our diabetes prevention intervention. Talk to you about how we designed our implementation strategy and the frameworks we used for that, and the extensive stakeholder engagement that we did. And then, really end with some take-home messages that I think are really a way forward in thinking more about how we can do better South-South collaboration. And that might be the new cutting edge in implementation science. How do you do that better? So we're talking about it right here. The Caribbean, unfortunately, is now suffering one of the truly epidemics of NCD in a way that we're seeing in many parts of the world, but probably more extensively in the Caribbean. So 8 out of 10 people in the Caribbean die of NCD. The NCD mortality in the Caribbean is actually the highest in the Americas. 40% of NCD deaths occur prematurely, so below the age of 7. Their diabetes prevalence in many parts of the Caribbean is double what we see here. And then obviously hypertension always goes. So it was really in light of this realization of this epidemiologic transition that was happening in the Caribbean, and the realization that what was now going to be killing people in the Caribbean was NCD, that it was the community of Caribbean states, otherwise known as CARICOM, that actually took the lead to bring together the first ever UN high-level meeting. So it's these individuals you see shown here that actually drove that. So that came out of the Caribbean, living in very deep. So to Trevor Hassel, who works with us very extensively today, and with Georgia. So it was in this setting that ECHORN was ECHORN is the Eastern Caribbean Health Outcomes Research Network, funded in 2011 by NIMHD, created a first of its kind research collaboration between Puerto Rico, USDI, Barbados, and Trinidad, giving us an opportunity to not only understand territorial disparities with USDI and Puerto Rico, but also to get that Caribbean context to inform that. So created a first of its kind cohort study following adults focused on NCD, but more so did a lot of capacity strengthening around research on NCD. We received a second grant from NIMHD to then expand this work to what we now call the Yale-TCC, which was mentioned before. So this gave us the opportunity to now bring in New York and New Jersey, which have, as you know, huge hubs of Caribbean descent population, but more so to now not only do cohort work, but implementation. How do we now translate evidence into practice and policy to address those gaps that were driving a lot of the NCD? This is where I come in. So in the implementation core of the Yale-TCC, that's what we do, is translate evidence into practice and policy, specifically around diabetes and hypertension. And these were the PIs. So these are our 4 PIs, our 5 PIs, including Dr. Marcel and Smith at the bottom, and then each this is a multi-PI grant, and so we have a PI in each of our island sites. So our implementation core, our first project was going to be about diabetes prevention. I'll just pause and say that the reason of all the NCDs, ECHORN focuses on cancer, cardiovascular disease, diabetes. They decided to do diabetes and hypertension because the stakeholder said that was really what they were seeing. So that's why we're starting here with diabetes as our first implementation project. Why diabetes? So things you guys all know, 1 of 7 major controllable disease risk factors. And then we know that even within the U.S., we have significant diabetes disparities globally. And yet, we actually know diabetes prevention works. I think we've had numerous studies now that show that, you know what, there are some things you can do to at least, maybe you would agree with me, delay diabetes. We know that it's cost effective. That data is also out there. And yet, you know, we have very limited uptake among populations with rising diabetes. We really have an urgent need for these sustainable diabetes prevention interventions that have high uptake among minorities. That's the gap. That was the gap we were trying to do. And so our project objective was to design an intervention to reduce the incidence of diabetes among Caribbean descent individuals, to use stakeholder engagement and implementation research methods to design an implementation strategy for that intervention, and to implement and evaluate that intervention using implementation. So this is the 30,000-foot view of Lyme. Lyme is an evidence-based intervention. It combines lifestyle modification and metformin medication, targeting the highest risk patients with prediabetes, with the end goal of reducing diabetes. So we do take the highest of highest risk. I'll show you some of these numbers, but it's overweight and obese with an A1C between 6 and 6.4%, so really high risk prediabetes. Expose them to lifestyle change, not the DPT. We can talk about that, and I'll tell you why and what we did end up using. But lifestyle change workshops that have been shown to reduce weight, at least among actually very diverse communities in the column. And then we give them 6 months. And if in 6 months you're not able to show that you reduce your A1C or reduce your weight, you get metformin, which per American Diabetes Association recommendations is what you take. So what's the evidence? Now, we always say in implementation science, what's your evidence? Is it ready to be translated? And so there are 3 trials that informed us. So one is the DPP, the Diabetes Prevention Program, published in 2002 in the New England Journal. Huge hullabaloo. I was the president at that time. And it was the realization that lifestyle change will prevent diabetes. Metformin does too, but just not as well. This was separate arms, lifestyle and metformin, not combined, which is critical, different from what we're doing here. Then there was DCLIP. DCLIP did do it combined. DCLIP was done in India, and actually combined lifestyle change with metformin. So started with lifestyle, gave people actually only 3 months, and then gave them metformin medication if they did not reduce their sugars or their weight in 3 months. They showed that they also were able to reduce it. And then there was HEED. So HEED is Dr. Carol Horowitz, right here in the column. did a 6-week diabetes prevention intervention among a very diverse community here in Harlem, primarily Puerto Rican, and showed that they were able to reach sustained weight loss at 12 months. They were not powered to see A1C, but sustained weight loss at 12 months. So you can see here that Lyme actually has attributes of all of these studies, right? So we have lifestyle plus metformin, we're sealing it, caribbean descent, and importantly, what's different from a lot of these studies, we are now integrating it into a healthcare system. And this was funny when I gave a version of this talk in Kenya, and one of the questions was like, you're bringing it to the health center, whereas many parts of the world are taking it out to the community. And this is again these kind of contextual differences that we have to account for and think about. But in the Caribbean, the primary care structure is actually pretty strong, whereas our community outreach is not as strong. Not globally in the Caribbean, but primarily Barbados, Trinidad, USVI, and Puerto Rico. So it was actually driven by the stakeholders that they should come to the primary care health center in a sense of to maintain sustainability. So these are our clinical sites. We're in 6 clinical sites in Puerto Rico, USVI, Barbados, Trinidad, 2 sites here in New York. One is at Sinai and one is the Union Community Health Center in Bronx. So I'll give you kind of the more detailed view and give you a little bit of the rationale behind elements of the study. So we screened for eligibility, and our eligibility criteria listed here. I'm going to give you the rationale for it. 40 to 60, they have to have a BMI or with elevated waist circumference. They do have to be linked to care. They have to have insurance, and we have a provider to prescribe them metformin. And then, like you can see here, the point of care A1C needs to be between 6 and 6.4. So why 6 to 6.4%? So you see in this bar graph here from the DPT, you get your biggest effect at 6 to 6.4. So this here is placebo, this is metformin, and this is lifestyle change alone, and this is cases per 100 person years. And you can see that for the 6 to 6.4, the difference between your intervention and your control was the biggest. But actually, you also get your biggest bang for your buck. So this is a quality adjusted life years gain, the cost of quality adjusted life year gain, and you can see that the curve starts to go up, so the cost increases per quality adjusted life year right after that 6.4%. So the lower you go below 6, the higher the cost for quality adjusted life year. So there's a rationale for really targeting your highest risk, 60.4. Why to 40 to 60? This is big, and our sites want us to bring in younger people. The limitation here is our control. So in our Caribbean sites, it was thought to be really difficult for them to recruit both intervention and control, given the sample size we were looking at. And there's also the real concern of contamination. It would be very hard for a provider to say, yes, you get metformin, you have an A1C 6.2. No, you can't get metformin, you have an A1C 6.2. So that not having them influence their care for control is very difficult. So our control group is our cohort study. I told you about the cohort study we have ongoing. They're recruiting their second wave now as we are rolling out the line. And so we're doing a frequency matching to kind of have a control group that avoids contamination. But the cohort starts recruitment at 40, so it's a start at 40. And the cohort, and metformin is only indicated up to the age of 60. So that's why the 40. Why BMI and waist circumference cutoffs that are not your traditional? These are the Asian cutoffs. This is primarily because Trinidad has a large Asian population. And why insurance? Sustainability. Because if I fund your metformin, if I pay for your metformin, if I pay for your labs, your providers, we're not going to have a model that can be sustainable once the project. So our primary outcome, we are powered to look at incidence of diabetes over 2.5 years. Our total sample size is 750, control and intervention, divided across all our sites. And you can see our secondary outcomes that are listed here. So before I move on, just to kind of walk you through the protocol per se. So you were 6 to 6.4, you come into the study, you get a baseline survey, some anthropometric measures, blood pressure, cholesterol, and creatinine, really just to make sure one of our exclusion criteria is an elevated creatinine because of the metformin. Then you go into the intervention. If you're intervention, you get the 6 weeks of lifestyle change. I'm going to tell you a lot about the workshops in a minute. But there's 6 weeks, weekly workshops, 2.5 hours each. And then after that, you get options in terms of sustainability components. So we have a different range of sustainability components. You can sign up for the app, for text messaging, you can join a local group, whatever you feel is best for you. And then we bring you back at 6 months, no weight loss, and A1C is still high, you go on that phone. And then we bring you back in every 6 months and we see what happens. So this seems easy to talk about, but not as easy to actually do, and not as easy to get people to actually do. So we designed it as a true, hybrid one effectiveness implementation trial. We're still needing to prove effectiveness, right? Lifestyle alone has been proven, our lifestyle alone has been proven to reduce weight, but not A1C, and so we need to prove that. And the combination of lifestyle and performance has been proven, so that's why it's still the hybrid. But why implementation in this community does not need to be shown on the slide. I'm sure you've seen it many times, but the latest research shows that we really should do something about this research. And so that whole trying to figure out how do we shorten the 17-year odyssey, how do we better address the actual no-do gap, that in this case is we kind of know we should be doing lifestyle, how do we really do it? We kind of know we should be giving metformin, but we're not really giving it. How do we address it? So community engagement, as I learned in my time in Tanzania the first time, is really kind of the cornerstone of it. Everything we do to some degree, at some element, at some phase, at some stage, as community or stakeholder engagement. There's a lot of terms that refer to a form of community engagement. These terms all refer to slightly different things. I will be primarily talking about stakeholder engagement, which is you can engage your community or stakeholder for formative research, fidelity research, methods research, dissemination research, ideally for all of them. Right? And why? Why is that important? Well, it's important because in order for us to develop solutions and translate this evidence, we really need to get context. And so this is East Harlem, and we're trying to translate a lifestyle change that was developed for East Harlem to this. We all want to be there. So this is downtown Barbados. Not too different. But we're also trying to bring it into a polyclinic. So Barbados clinic, very busy, high volume. What our equivalent of our community. So how do we do that, right? So we really kind of took to our stakeholders, and you'll see our implementers as well, to think about the actual implementation strategy of how we roll this out. And we actually talked to them a lot about the workshops themselves. And they themselves, even in the get-go, identified that really thinking about what that workshop curriculum looks like and making sure it is extremely relevant to their communities is a cornerstone of anything that you do regarding this project. Because if they don't see that, then everything else will fail. So we'll talk a lot about how we engage our stakeholders in these two things. So who are our stakeholders? So this might be a little bit different from what I think generally we envision as stakeholders. So we have a regional approach to stakeholder engagement, which I think is how ECHORN really is different from a lot of other projects. So we really feel that with the region of the Caribbean and the many similarities there are in the Caribbean, we should be able to design interventions that we can easily take from one island to the next. There will be differences, but if we have a regional approach to stakeholder engagement, we can bring out those similarities, but still highlight differences, right? And so we do. We have organizations that are academic institutions, community-based organizations, faith-based organizations, healthcare delivery systems, patient advocacy groups, professional organizations that really span the Caribbean and the U.S. There are over 55 stakeholders, and they're divided into work groups, and each of the work groups actually works with a different component of our ECHORN project. You see Sir Trevor here, his picture is part of he's one of the co-chairs of our governing board, one of the heads of the Healthy Caribbean Coalition, the largest civic-society organization in the Caribbean, and one of the people who made that call to the UN high-level meeting as part of CARICOM. So I work closely with the Implement Equity Consultant, but I work most closely with Sharon Williams from the USVI, part of a community-based organization, and who leads our implementation. For this first part, which is designing the implementation strategy, we not only needed to engage our stakeholders, but this is where we also needed to actually engage the implementers, right? and have them kind of cross off and talk together to think about it. So we decided to engage our implementers not only through just come and let's talk, but through capacity strengthening. How do we not only get you to inform implementation of this intervention, but how do we increase the readiness of your organization to implement evidence-based interventions in the future? So that you're not only gaining knowledge around how to better do this project, but could potentially apply it to other things in the future as well. So I'll tell you about our capacity strengthening. We actually shaped everything, our engagement with our stakeholders, as well as our engagement with our implementers using REAIM. And it's interesting, you guys have all heard of REAIM, but REAIM has not been used historically for designing interventions. Right? Historically, we think of REAIM as our evaluation framework, easy go-to evaluation framework. And so we knew that we would probably use REAIM in the future. But what our actually capacity strengthening teams have come to say is that, we really should be using this to start thinking a priori about all of these important components. And we already know these. We know that it's important. We know that adoption is important. But these are easy terms to start talking to implementers about, and to start talking to stakeholders about, to kind of frame our discussions using this framework. And so, these definitions of REAIM, you're probably all familiar with, and now we apply them to what we're trying to do for the live project. So how do we engage people who have prediabetes? How do we engage men, historically the hardest population that they can, right? How do we engage them in lifestyle and behavior change? How do we get people when there are hurricanes, right? So after the hurricanes, and you sit down and you're like, now what, right? How do we still reach when there's other priorities in people's lives? How do we increase retention? How do we increase adherence for adoption? How do we get providers, administrators, and front-level staff to buy into this intervention so that they are making the call, come back for your workshop next week? How do we actually get people engaged? And then implementation and maintenance sustainability. So we engaged our stakeholders through stakeholder engagement meetings. So as I said, the implementation work group itself had about 11 members. We had virtual meetings, and each of these meetings addressed a different component of the engagement. And I'll tell you what the results of the implementation strategy looked like. For our implementers, we had these capacity strengthening trainings. And so we paired up the sites. So we did Trinidad and Barbados together. Puerto Rico and the USVI went later because they were hit by the hurricane, because of the delay for them. And this capacity strengthening training was like, let's huddle up. Let's work together, because your sites can actually cross off and learn from each other. What challenges do you foresee happening for you rolling this out? How do you foresee your clinic addressing these issues of reach, effectiveness, adoption, implementation? So we had a series of capacity strengthening trainings. These were all virtual. These all are working virtually, which, the Caribbean is very good with, but it's not their preferred modality. Laverne Baxter, one of our former president emeritus of the University of the Virgin Islands, who's one of our governing board co-chairs, said, we prefer in-person. And they really do. There's not money for that. But they do really well with virtual. We do Zoom. Everybody's on video. And we have these discussions, and we usually have a professional facilitator who's helping us facilitate these discussions. So you see here that each of the capacity strengthening training sessions kind of had the team work together to think about these different components. So what did it eventually look like? So I put kind of here simplified process, right? So we want individuals in the community that are served by the clinic to be screened for prediabetes. And then individuals who are at high risk of developing diabetes identified. Those high-risk individuals should be sent to lifestyle workshops. Those high-risk individuals should adhere to the lifestyle changes. And then those pre-diabetic individuals, patients with prediabetes, should, if they're not successful on lifestyle, be given medication and adhere to their medication. And then what's not shown here is the end result of that, hopefully, is that you don't develop diabetes. So based on everything that people gave us throughout these stakeholder engagement meetings and implementer meetings, we kind of modified or added components to that kind of process to really address how do we get better reach. So, and some of this is kind of intuitive, but it's nice to kind of see it come out through these discussions. So partnering with community and faith-based organizations, so one of the largest faith-based organizations in Barbados, the Church of Nazarene, Pastor Farley is one of our stakeholders, and would just routinely talk about life at the time. And so people kind of got familiar with this language from a different setting. What's nice here, and what people have highlighted, is that it's unusual, Dr. Benga and others have kind of started to do this work. It's great when people hear the same message from different people. When you're hearing the same message from your faith-based leader, when you're hearing the same message from your community-based organization, from your doctor, that's when the message kind of hits home. And that's kind of what this is. Newspaper, radio, TV broadcast. Radio is huge, biggest source of information in the Caribbean, and so everyone got on radio. Testimonial videos for men. So on our website, we have up one of our testimonial videos that only teaches men, talking about the lifestyle modification changes. And, our stakeholders thought that would be the best way to get men to say, you know what, this is what I need. And so, often the extremists in each of the clinics. For adoption, leadership support is key. So we had for each of the clinics really hold meetings that were led by their leadership. Leadership doesn't always show up to all these meetings. So when the head of the Ministry of Health clinics comes to these meetings to talk about Lyme, even if I'm on Zoom, I'm talking about the Lyme project via Zoom, they're there to kind of say, we support this and we think we should do this. That also means that leadership support should provide the time, the protected time for providers to do this work, and that's clearly critical and is a big part of adoption as well. So maximizing effectiveness, a lot of that kind of comes out a little bit here is really around the lifestyle workshops. That we need to really think about how we're adapting these workshops to our community, and that's how we're going to get to effectiveness. And I'll talk a little bit more about application. And then there's more adoption. Maintenance and sustainability, again, engaging those higher level people, thinking about sustainability, the lifestyle change in particular. I was talking to Dr. Mary Sevick this morning and about the difficulties of sustaining lifestyle change, and that it's not easy. And how do we do better at that? But they very early on said, you got to figure that out. If you don't, then it's very hard to kind of sustain the intervention. And then continued provider education to take into consideration. So the other big thing was what they had highlighted, which was these workshops, right? It's none of this is going to work if you don't properly adapt your workshop. So let's talk a little bit about what the source of these workshops is. So this really stems from the Chronic Disease Self-Management Curriculum. This is a 6-week curriculum developed by Kate Lorig at Stanford, shown to be effective and cost-effective, initially geared towards multiple chronic diseases. This was modified to diabetes self-management, shown to be effective and cost-effective. And then Carol Horowitz turned that into diabetes prevention. That is what he did, help educate to eliminate diabetes. This, Dr. Horowitz actually did it through a complete CDPR approach with a community-based organization in East Harlem, who themselves identified this curriculum as being good for them, who themselves said DPP is too long and too cumbersome, and we don't want to do that. And that's why that was the incentive behind taking a shorter curriculum, which was the CDSNP, and transforming it into diabetes prevention. So it was he that showed sustained weight loss for 12 months, again, not powered to show reduction in weight. So what we now wanted to do is to take HEED and make it into Lyme. Right? How do we now take these HEED workshops developed for East Harlem and modify them into these Lyme workshops we could use for Caribbean descent populations? So we wanted it to be culturally appropriate, culturally relevant, and culturally sensitive. And we'll talk specifically about what that meant to us. We did want a stakeholder engaged approach, and so our first question was, who's not at the table? Who needs to be at the table? Right? So we had our implementation work group members who are stakeholders, but the obvious one was the nutritionist who can adapt the kind of the nutritional components of this to each of the items sites. But we also need to make sure we have people with pre-diabetes who can really are living with this problem and speak a little bit more to what this means. And most importantly, we need the people who originally developed this HEED curriculum. Okay? So when we talk about fidelity, when you're making changes, if you don't know what components of the intervention are critical, or what components of that workshop are critical, how do we then know that what we're changing is what we should be changing and won't affect the effectiveness of the workshop? So we brought these people together, and we went through a series of stakeholder engagement meetings. We adapted the nutritional content. That was probably the easiest to do. We did cultural adaptations I'll tell you more about to kind of gear more to cultural norms in the region. And then we had a last wave of workshops, engagement meetings, specifically targeting the post-hurricane setting. and what changes did we need to make to be sensitive to those particular concerns. I'll give you more details in a second, but really the hope was that in the end we had these culturally appropriate, sensitive, and relevant language. So a little more on adaptation. And Dr. Chambers has kind of spearheaded a lot of this effort now around the science of adaptation, really making a call to the implementation science community to think more systematically about how we adapt in a way that will not only allow us to replicate, but also to better understand those core components versus those adaptable components. And so I'll talk a little bit about his adaptome, this theory of this database of adaptation that we should all be thinking about creating. But this is the idea that when you have a genuine intervention, you have all these adaptations with these subletters right here, and some of them will be what he calls positive deviance, adaptations that actually make it more impactful. And then there are these adaptations that make it less impactful, causing risk. And so when we think about more systematically thinking about adaptations, there are a few frameworks out there that have been proposed as how to think about. This is not the one that we ended up using, but it's really thinking about what are your core components. Those are the ones you should never change. Then there are the cultural adaptations, mode of delivery adaptations, target audience adaptations, your service setting adaptations, and then you have your intervention. And if you can systematically say what exactly you're changing in each of these layers, then we can start to get a better understanding of what adaptation really means, and to what degree something is being adapted, and how my adaptation is different from your adaptation. And his idea was that you develop these components, and you have your core components in your adaptation, you feed all this information into like a genuine kind of central database, this adaptome. And by understanding this adaptome, you're then able to use that information in that data platform to think about not only what are core components, what are adaptable components, but how do we now think about how the contextual factors can affect this? And then if I understand this, I can say, okay, that means that if I'm now going to this setting that has these different contextual factors, I need to be using these adaptable components from this intervention and these adaptable components from that intervention to design my intervention. It would be great. Like, this is what he's saying we should be doing. Right? So this is Sturman et al.'s model for framework for adaptation, which I actually really like. To think about who is making the modifications, what exactly is being modified. And when you think about what is being modified, look at content, context, and training and evaluation, at what level of delivery, and then what is the nature specifically of the content modification. So I'll show you how we use this So we didn't have any training modification, training and evaluation. We used the same training protocol that the CDSMP, that original program, uses. We used the same evaluation protocol that that original program uses, but we did have several content and context adaptations. So for content, the big thing was framing. The big thing that they really didn't like was this being framed as a weight loss intervention. Right? So they did not want that. And the reason is body image is perceived differently in each interview. And so a lot of people are very happy with their body image. They don't want to lose weight. If you tell them the reason to be here is to lose weight, they really may not be interested in being engaged. So it's more about acquiring a healthy weight and not being what's driving the kind of framing of it. So we didn't change the intersection to talk about that. The other thing was the introspection in the post-hurricane side, okay? To talk more about why this was so important in the post-hurricane setting. Why, if anything, your ability to self-manage your disease, to self-manage your sugars, to self-manage your diet is even more important when you don't have that easy access to primary care office. And so I will pause here and say that we just spent a lot of meetings with our Puerto Rico and USDI teams after the hurricanes to ask them, should we just kind of scrap it? Should we just not do this here? And it was a unanimous, absolutely not. Like, if anything, we need this now, not only to focus us on what is healthy, but also because there's a strong emotional component to this workshop. There's a whole section talking about the emotions around eating and emotional well-being and how that drives your health and your diet. And so we actually vamped that content up to give more space and time for the post-hurricane sites where we knew there was going to be a lot of more emotional content. So that's the role of emotion that we're kind of gone into. Island-specific nutritional content, again, we can say, like nutrition page out, that these are the examples of the foods we eat, change these and change that. That was actually something. And then sustainability. So adding more language around the different options people have to sustain the lifestyle changes they can make. So we have an app that's related to the workshop series. We have a text messaging platform that they can sign up for and just get monthly reminders around the workshop content that they learned. And then we have a repository of local fitness groups that they can try. Context adaptation. So again, we did much more targeted engagement with men, which I spoke about. And we really did encourage family members to attend. And so the people at the table who were from the original SEED program, they said, it's absolutely okay for us to, the stakeholders felt very strongly that it wasn't enough just to bring the one person in the family. The more people in the family at the table to kind of undergo this lifestyle change, the more effective it would be. And the SEED developers said, that's fine, but they have to commit to coming to all the workshops, because a big component of this, one of the core components, is the work group dynamic. And so the work group dynamic that's created, they really felt was integral to the success of the workshop. So people can't just come and go, right? If you commit, you can come, you're a family member, you don't have prediabetes, and you're still going to learn a lot, but you can't come and go. So that was the adaptation. Another very interesting one is that this curriculum was developed to be peer-led. Not to say providers can't lead it, but it's really meant to be peer-led. Our stakeholders really felt that people would buy it more from providers. So they really felt that they didn't need it to be peer-led, and that people would really believe the information coming more from the doctor than it was coming from, their next door neighbor. So that was kind of interesting for us. Not that it changed necessarily the fidelity to the workshop curriculum. The peer-led just allows you more flexibility in how you can administer it. Okay. So at the end, we had our key core components. So these are the things we shouldn't touch, that they said we shouldn't change: the dose, the duration, 6 weeks, 2.5 hours each. Don't touch that. You can't change the dose. The action planning and feedback. So the whole curriculum is self-efficacy based, right? So at the end of the workshop, of the session, you develop an action plan together for how you are going to change your lifestyle in the next week based on what you think is feasible for you. You come back the next week, you start with a feedback session. How did it go? What worked? What didn't work? Those they felt were two core components of this curriculum. Do not touch them. Problem solving. So the whole element of problem solving is integrated throughout the curriculum. How do you problem solve these health problems when you're faced with them on a daily basis? The self-management toolbox, again, is critical. So touch that, change that. The group dynamic I talked about. And then having two leaders, the co-leading model, also touched. But then we had the adaptable components to make them culturally appropriate, culturally sensitive. So, through this process, we've been able to do a lot of capacity strengthening in regions, so we've been able to train master trainers in Barbados, Trinidad, USDI, and Puerto Rico, who not only can do our diabetes prevention line curriculum, but also the chronic disease self-management and the diabetes self-management. And what master trainer means is that I can now teach you how to lead workshops. So we now have kind of an ability to continue a stream of trainers with just training one person as a master trainer. And by actually doing these training sessions, we're essentially piloting the workshop. Because what they do is they run the workshops with these people who are being trained. And so we're able to pilot it, to get some information and feedback, have some proposed changes, adjudicate those changes with our group of original team developers, and then adapt the content again. So we're making some minor changes. Minor changes as we were kind of rolling out the training. So these are our certificate proud teams as they finish their trainings in Trinidad, USDI, Barbados. So this is my transition. So that is essentially how we developed it. So we're now rolling it out, and I'll give you a little bit of where we are in the timeline. Well underway in Barbados and Trinidad, starting in USDI and Puerto Rico. But the same way before we kind of get there, just thinking about how we're going to evaluate this, and again using ReAIM. What's nice about having ReAIM to design it, now it's a nice segue to the evaluation component of it. We are doing a mixed methods evaluation of ReAIM. For our qualitative work, we are using the SUSA. This is actually part of my K-12, so the NIMHD-funded implementation science K-12. And my interest is really understanding how contextual factors in each of these sites is going to influence effectiveness differently at each of the sites. And so we're using the consolidated framework implementation to do that. So we've kind of completed our trainings in all of our sites. Barbados and Trinidad are halfway past their recruitment goals, and they've actually completed their first round of workshops with about 80% retention at 6 weeks, so people coming to each of the 6-week sessions, which is great. We haven't analyzed our pre and post data yet to see to what degree their lifestyle changed from right before the workshops to right after the workshops. That'll be interesting, so we should be able to have that data soon. We've created a Lyme advisory board that not only has our implementers, but actually participants who've been very engaged in the study, who are now part of our Lyme advisory board that meets every 3 months. We're continuing to make small tweaks based on what the Lyme advisory board feedback is. Like I said, the workshops are started and we'll keep doing that. So, before, I just want to kind of do some take-home messages before we talk a little bit about what this means for the kind of greater global work. So we really feel that Lyme does have a potential to address the rising burden of diabetes in the Caribbean and among Caribbean descent populations. The reading framework is really nice. I mean, this is the first time I used it before the value. This is the first time using it in designing and kind of talking to stakeholders and influencers, and we thought it was a really nice way and easy way to do that. But also to really inform us of those key elements that have historically limited the sustainability of substance abuse interventions, which are primarily reach and adoption. Capacity strengthening training with implementing sites can really help the issue of adoption, and engaging with key stakeholders in the community can help with the reach and effectiveness issue. Using our regional approach to stakeholder engagement, we've been able to kind of identify those core components, but those adaptable components that we can now say, okay, what are the cultural, appropriate, relevant, and sensitive issues that we can now tweak going from island to island now that we've kind of identified the core components. So the regional stakeholder approach has allowed us to make something that we could easily take from one island to another. And so, with that framing in mind, and kind of thinking about that regional approach that we took to stakeholder engagement, and thinking about how do we define core components, adaptable components, this adaptable idea. How do we now take it that step further? How do I say now that I'm going to take something from the Caribbean and now take it to East Africa? So how can we start to better understand that and better do that? And the argument I want to make is that by building implementation science frameworks in the South, we can be much better positioned to do South work. By better understanding how interventions work for the South. And there are components of these frameworks that actually don't work. And there are components in these frameworks that don't include a lot of the governance issues that we deal with. In the presentation this morning around work in Tanzania, all those system-level changes and challenges we ended up facing were not included in the secret, right? In the contextual framework implementation. And we have to add those in as we go. So I'm going to use Sub-Saharan Africa as an example, right? As to why it's a comparable place in many ways, and a lot more comparable than looking at interventions done in the North. So when you look at the World Bank classification for high income and low income, which is over here, you kind of make the assumption that maybe Latin America and Caribbean is much more high income, and they are, like Barbados is classified technically as a high income country. But when you look at the GDP per capita of Latin America and the Caribbean compared to the U.S., compared to Sub-Saharan Africa, they're a lot closer to Sub-Saharan Africa than they are to the U.S. So all this to say is that when you look at those classifications of high income, middle income, and low income, the Caribbean, I still feel for the largest part, is still in many ways a low and middle income. So not only do you have that similarity in terms of low and middle income, but you also have huge similarities between the Caribbean and Africa in terms of race and ethnicity, with a large proportion of African and minority really who are Asian. And then I take this from the global burden of disease study. And just to orient you, so the top is Caribbean, the bottom is Sub-Saharan Africa. And this is data taken from the United States. This is disability adjusted life. Blue is your NCDs, your chronic diseases. Red is your infections. And you can see here in the Caribbean, even in the 1990s, about half and half. Definitely in Sub-Saharan Africa, it was more infectious disease. And then we move to 2016. And let's go back and forth. And you can see that both of them have a shift. right? And the point here is to make it that both of these regions are experiencing that epidemiologic transition. That is not something our northern states are experiencing. There are things that are completely unique to understanding that epidemiologic transition and how you need to shift your infrastructure from dealing with infectious disease to shifting your infrastructure to dealing with chronic disease that we can only learn from studying things in other countries. So again, the evidence base that we have right now comes primarily from high-income settings. Adaptation is really necessary when we think about the adaptome. We need to create that adaptome, that repository of adaptation techniques and what is core and what is adaptable. We need to develop that in southern countries. If we develop that in developed countries, we're not going to be able to learn from that as much because of all the differences in similarities I talked about. So they need to really emerge from low income countries. So we have similar common no-do gaps. We have many similarities in our contextual factors, and we have similar populations now as we think about parity. And so, moving forward through collaboration, we're going to be able to not only tailor those implementation science tools. What I was talking about before is that there are gaps within Yale, there are gaps within CISA that are not incorporated these low and middle income country issues, such as governance, such as these system level issues. So someone actually presented at the DNI conference last year, this past one, a systematic review that they did of the use of the consolidated framework for implementation research in LMIC, and all of the components they felt out of that dealt primarily with the government structure. And actually, Dan Schroeder was at that session and was, you're right, this wasn't developed there. And so we need to learn from each other by doing more of this. Building the adaptome, like I talked about, key for us to build that database from within low and middle countries. And the size of scale-ups, I didn't talk as much about. I know Raj and I have talked a lot about scale-up and thinking about what that means in the science of scale. But scaling up something in the U.S. is completely different from scaling up something in Kenya or Tanzania. And we need to learn from each other on how to do that. So the epidemiologic transition is really experienced by many LMICs, but we have to address it by accelerating translation from evidence to practice within LMICs. Implementation science and stakeholder engagement is a critical role to play in that process. And similar research experiences in the Caribbean and Sub-Saharan Africa, really with many LMICs in general, can be leveraged to move the field of implementation science and its applicability in LMICs forward, and especially the size of adaptation and scale.
Thank you.
So my question was about the sustainability and seeing the participants being enrolled into being insured, and then in the end we're kind of like comparing with Sub-Saharan Africa, where we know like most people in most countries are not insured. What are those rates in the Caribbean? Are most people insured, or is it only a portion of the population?
It's a very good question. So in Barbados and Trinidad, they have universal health insurance. So it's common. In Puerto Rico and the USDI, it's primarily Medicaid. It's not dually eligible Medicare and Medicaid. But you're right. That is a big difference from some parts of Sub-Saharan Africa, not all, but some parts of Sub-Saharan Africa. This intervention in particular, the biggest component that's driving costs is your A1C test. So you have to think about other ways of identifying a high-risk population for lifestyle change that wouldn't be dependent on it. Metformin not as big of an issue. There in terms of cost.
Very nice, thank you, Saria. Question, and I may have missed it when you presented, but did you talk about your sort of analytic approach to determining effectiveness? Like, is it a randomized thing? Is it not? What's your comparator?
Yep. I'll talk very briefly about that. So for, it's not randomized, we're calling it pragmatic. So our control population
is your cohort.
Is our cohort. So what we're doing is frequency matching by age group and BMI class. So those are the two things we're frequency matching by. There were some additional things we wanted to frequency match, but we were concerned about overmatching, so we're sticking to those two. So what we do, like in Barbados now, we've passed kind of halfway improvement. So we're looking at our number in age group of 40 to 50, number in age group of 50 to 60, and Barbados has just finished its wave 2 role. And so those people who meet those frequency match, we call up and bring them back from the cohort.
They're not attending the same clinic?
No. For the most part, no. There are some. So there might still be some element of contamination, but not all of them are in the two clinics in Barbados.
Got
So we're only 2 clinics. And definitely not in Trinidad. Trinidad is, in the east of Trinidad is where the cohort is, and the intervention is in the southwest. Trinidad much larger.
Got it. Then sort of 2 related questions. How are you taking into consideration potentially different contexts, therefore, of your comparator versus intervention group in terms of your analytic approach, number 1. Number 2, given that you're planning to do all of these adaptations, whether they be micro or macro or regional, is there some, again, analytic implication in terms of adaptive trial design and that kind of thing? I'm just curious if you guys have been incorporating that.
Yeah, so the adaptive trial design is we're not given as much thought. I think, the adaptation process is more trying to really think about what are core components and what are adaptable components. How well will be powered to kind of do a true adaptable trial design? I'm not sure. We really haven't thought about it. That's a great point. With regards to the context, so we'll be able to control for a lot of things based on our survey data. So in terms of neighborhood level factors, socioeconomic status factors, we'll be able to control for between the control and the intervention. So I'm hoping that we won't have as much of a discrepancy between the two. But they don't.
Yeah, that's very similar to follow on to this. Thinking about that too, how you're going to analyze the data, especially if the adaptations are profound. But it sounds like they're more minor. They're a little bit more minor, and so you expect the effect on the overall outcome to be more subtle. Is that fair? Or you're doing most of your adaptation before the workshop, right? You're doing
absolutely, yeah. The ones that are happening now are very minor. So, for example, if you start with a total group of 15, you can see that you're going to lose 2 or 3 people. Maybe you should start with 18 so that you come down to 15. So just like small things like that are not curriculum based. The big adaptation happens very upfront. Now, I thought you were thinking more to there are some differences between items. Right? So the nutritional content is different between items. We don't think that will affect the state. Everything else really is consistent between items. What we won't be able to see is how this is different from the original. Right? So I can't study that. But between our island sites, we really should be very, very different.
I was thinking when you were presenting the adaptome and the adaptation framework, very similar to what we use here in our bottleneck analysis framework. So we start with an intervention and ask why it's not 100% effectively covering the population. So is it the availability of resources or the accessibility, or in your case, the acceptability, the cultural acceptability of it? But we also add in the continuity of those resources, so whether or not they're there when people need it, and then the quality. And for us, we've used a Tanahashi model, which has the hierarchy, but also it's sort of, there's a hierarchy of bottlenecks, and then try to quantify that. But I was really amazed at how well it lines up with what you're doing here, because I think it could be really effective in how we approach looking at interventions as well. It's really fascinating.
I'm not sure if you explained this, but I know that you said you use the REAM for to design, but then to evaluate, you guys use the is the reason why you just continue with the same model from disability growth?
Yeah, so we are definitely still framing our evaluation around age. So we are. But when we look at qualitative data, though, we'll still group our barriers and facilitators and the map to barriers and facilitators of effectiveness, adoption, and patient neediness. But what I'm really interested in are the contextual factors that influence implementation, and specifically implementation effectiveness. And the CFR does that really well. So we're using the CFR to analyze the data. That doesn't mean I could still, even after doing that, map it to better understand reach, better understand effectiveness, better understand adoption. But in terms of an analytic framework for analyzing the qualitative data, it's powerful in that way. So that's why it's kind of more because of my interest in contextual factors and using the CFER to better understand implementation effectiveness and factors influencing implementation effectiveness that I'm using it, but we'll still be able to apply it to the VA within this method. So Dr. Schroeder has put out a nice paper looking using the CFER to understand implementation effectiveness of the VA DTC and why were some sites kind of better at doing it than other sites, and how can we take our qualitative data using the CFER to better understand what those factors were, so that then ideally if I take it to some other place, I can say, oh, it doesn't matter if, you know, your outer setting stuff is, if you're not addressing the patient using it. You can better understand which of those inner setting, outer setting, intervention characteristics, individual characteristics, which are the domains of the CFER, are most important in influencing the effectiveness. So that's my K-12.
What are the lifestyle changes? Are they changing their diet? Are they changing exercise? Or what are they?
So those are the two primary things that we talk about is diet and exercise.
And they're going to do calorie reduction? Are they changing the mix of what they're eating?
So it's increased fruits and vegetables, overall reduction in calories, and decreased sugar sweet.
Okay. And then exercise, they have access to a gym, or are they doing it outside, or how are they?
So there's no, so most people are doing walking outside. They're pretty at the gym. But, so there are, what we are finding from our survey data, there are very limited numbers who actually have access to the gym. Our app does give them kind of a list of resources of local gyms, the rates of the local gyms, and the park where you can walk. And again, post-hurricane different because there are a lot of areas that are no longer accessible for walking. So kind of figure out. But most people, so what most people have done is they actually create a WhatsApp group from within the group that's in the work group, and then they say, hey, I'm taking a walk this weekend, join me, and that's kind of pulling, that's their action plan. We're going to all take a walk.
Do they monitor that? They track it and provide that to you, or is that just?
No, so we don't have activity monitors. So our physical activity report is only by health report, so global physical activity question. So when we see the WhatsApp, it's more of their report of when they come to report at the feedback session, what did you do? My action plan was to do a walking group with everybody in this work group, 2 people. So that's how I get that. So we don't have that. So our survey domains are all the socioeconomic factors. We have self-efficacy scores. Self-efficacy score. We have the global physical activity questionnaire. We have the DST for our nutritional evaluation. And then we have our clinical assessment data, which is the blood pressure, BMI, waist to hip, circumference, and exercise. So those are all both the survey and the clinical assessment data. The last one is the lab component, cholesterol, and cholesterol. So we collect that on everybody at baseline and every 6 months.
So what are your intervention arm is receiving the line, and then what are the controls?
They're not getting, for the cohort study, all of they're getting is some basic information about prediabetes that comes with the consent.
And do they get metformin?
So because this is an intention to treat, so once they get metformin, they're no longer kind of fall off. Yeah. They fall off. So that could happen. Yeah. So when they come back, we ask them what meds they're on. So when they come back at their next visit, if they're on metformin, they can't continue using it as a control arm. And the same with the intervention arm. So if for some reason they get put on metformin before they come back for their 6-month visit, that's an element we don't, they'll continue the study, we just have to account for the fact that they got metformin early. Highly unlikely. We have 1 person in our 3,000 person cohort who has prediabetes on so not routinely prescribed. The issue is the endpoint of diabetes. So if when you come back, you have a point of care that's A1C is diabetes, you need to get a confirmatory serum A1C, and now you have diabetes, and that's the endpoint. So those intervention controls.
So all the controls get is just information.
Yep. So during the consent form, we give them some very basic information about what prediabetes is, because they may not have been told like and what the recommendations are for management. So they're just part of the system. Information about how to manage, which is standard of care. So there.
So unless there are any questions, I think that there's a time you're supposed to meet at 2:30, 2:30, right?
Is there anything from the left, Gilbert?
No.
All right. Well, thank you so much, Dr. Really fantastic.
One thing.